Guidelines of central neuroaxial blockade in a patient on anticoagulant therapy.
Okay.
Yes,
It's also a very often repeated question. And also
okay.
examiners are very fond of asking this: if the patient on anticoagulant therapy, when will you do an epidural, when will you remove the catheter, when will you inject the drug? All those questions are very common. So you have to have a very clear concept about this. Go ahead.
Okay. Yes, sir. Patients most likely to benefit from the regional anesthesia are often treated with anticoagulants, which increases the risk of hemorrhagic complications, mainly vertebral canal hematoma, which may result in permanent neurological complications. Therefore, decision-making strategy of patient at risk of bleeding is important when considering neuraxial or regional anesthesia technique. Common indications of antithrombotic therapy: venous embolic diseases like deep vein thrombosis and pulmonary embolism, arterial thromboembolic diseases like prosthetic heart valves, mitral valve disease, atrial fibrillation, neural cardiac thrombi, transient ischemic attack, stroke in evaluation. It's also used in disseminated intravascular coagulation, maintenance of patency of vascular grafts or shunts or bypass. So the antithrombotic drugs include antiplatelets and anticoagulants. In anticoagulants, we have cyclooxygenase inhibitors, that is aspirin and NSAIDs, and then we have P2 white cell receptor antagonist. In the thienopyridine groups, we have clopidogrel, prasugrel, and ticlopridine. In the non-thienopyridine groups, we have ticagrelor and cangrelor. And then we have glycoprotein 2B3A receptor antagonist like abscesimab, tirofiban, eftifibatide. Then we have phosphodiesterase inhibitors like dipyrimidine and cilostazol. In anticoagulants, we have heparin, which binds to antithrombin and inhibits thrombosis by inactivating the activated factor 10A and 2A. And then we have low molecular weight heparin, which selectively inhibits factor 10A. And then we have fondaparinux, which is synthetically derived potent selective factor 10A inhibitor. And then we have direct thrombin inhibitors like agrotraban. And then we have oral factor 10A inhibitors like rivaroxaban, apixaban. And then we have oral thrombin inhibitor 2A, that is dabigatran. And we have warfarin, which inhibit the vitamin K dependent clotting factor production. Production of factors 2, 7, 9, 10. And then in pre-anesthetic checkup, the history specific to antithrombotic therapy should be noted. That is, if the patient is on antiplatelet or anticoagulant therapy, if so, what is the indication for the therapy, and what is the drug dose and duration of the treatment, and what is the effectiveness of the treatment. Consideration for patients on antithrombotic therapy is mainly a risk of thrombus formation, risk of hemorrhage, and then if or not the patient is on bridging therapy, and risk benefit ratio of stopping the antithrombotic therapy. The American Society of Regional Anesthesia recommended time intervals after stopping the treatment at which performing regional anesthetic technique may be safer. It also suggests time interval at which the treatment with anticoagulants or antiplatelets can be restarted after the procedure removal of epidural catheter. So the guidelines: antiplatelet agents, first clopidogrel, which should be stopped 5 to 7 days before the procedure. In case of both the high risk and intermediate risk procedure. For low risk procedure, there is no need to stop clopidogrel, and it is usually restarted 12 to 24 hours after the procedure, 12 hours in case of usual dose and 24 hours in case of loading dose. And then prasugrel, which should be stopped 7 to 10 days before both the high risk and intermediate risk procedures. For low risk procedure, no need to stop, and it has to be restarted after 24 hours of the procedure. And then coming to ticagrelor, which should be stopped 5 days before both the high risk and intermediate risk procedure. In case of low risk procedure, no need to stop. It also has to be restarted 24 hours after the surgery. And then cangrelor, which need to be stopped 3 hours before the surgery for both high risk and intermediate procedures. And then it also to be restarted after 24 hours. And then abscesimab, for both high risk and intermediate and low risk procedure, it has to be stopped 2 to 5 days before the surgery. It has to be restarted 8 to 12 hours, after 8 to 12 hours. And then eftifibatide and tirofiban, both need to be stopped 8 to 24 hours in high risk, intermediate risk, and low risk procedure, it has to be restarted after 8 to 12 hours. And then coming to anticoagulants, warfarin, in case of high risk and intermediate risk procedure, it has to be stopped 5 days before the surgery. And in low risk, it need not be stopped. It has to be restarted 6 hours after the surgery, given the INR is less than 1.5. And then IV unfractioned heparin, it has to be stopped 6 hours before the surgery for both the high risk, intermediate, and low risk. And it can be restarted 2 hours after the procedure. For subcutaneous heparin, in case of high risk procedure, it has to be stopped 24 hours before the procedure. In case of intermediate and low risk, it can be stopped 6 hours before the surgery. In case of low risk, it can be restarted 2 hours after the surgery. In case of intermediate and high risk procedure, it can be restarted after 6 to 8 hours. And then we have enoxaparin. In case of prophylactic dose, it has to be stopped 12 hours before the procedure, and it can be restarted after 4 hours in case of low risk, and in case of intermediate and high risk, it can be restarted after 12 to 24 hours. In therapeutic doses, it has to be stopped 24 hours before the high risk, intermediate, and low risk procedure, and it can be restarted after 4 hours in case of low risk procedure, after 12 to 24 hours in case of intermediate or high risk procedure. And then we have a fondaparinux, which has to be stopped 4 days in case of high risk and intermediate risk procedure. In case of low risk procedure, it need not be stopped, and it has to be restarted 6 hours after the low risk procedure and 24 hours after the intermediate and high risk procedure. And then we have dalteparin, which has to be stopped 24 hours before the procedure for high risk, intermediate risk, and low risk, and it can be restarted 4 hours after the surgery. And risk factors associated with other risk factors associated with spinal hematoma is female sex greater than or equal to 65 years of age, abnormality of spinal cord or vertebral column, patient at high risk of hemorrhage, that is easy bruising and excessive surgical bleeding, traumatic needle placement or catheter placement, epidural technique, indwelling epidural catheter during low molecular weight heparin administration. Sir, I will left the investigation, sir. Investigation specific for patients on antithrombotic therapy. In case of warfarin, we have to specifically check for INR. For heparin, it is APTT and activated clotting time. In case of low molecular weight heparin, anti-factor 10A level. Case of dabigatran, APTT and thrombin time has to be checked. In case of rivaroxaban, anti-factor 10A and prothrombin time to be checked. And we also have to ask for platelet counts, LFT and RFT function. In summary, since there is increased number of available anticoagulants and patients receiving them, we should consider the challenge of balancing risk and benefits of regional anesthesia. It is important to do thorough pre-op evaluation and physical findings, as well as awareness of post-op plan for anticoagulation and post-procedure close neurological monitoring in all these patients is imperative.
Excellent. That's very detailed, and you have covered all the points.
Yes.
What are the indications for anticoagulant therapy?
Sir, main indications mostly DVT, sir, deep vein thrombosis, pulmonary embolism, and acute coronary syndrome, sir. A patient on prosthetic valves and any vascular grafts, shunts, and transient ischemic attacks, sir. Past history of TIA and stroke for evolution, sir.
Okay. So these patients have a risk of going in for a thrombosis again if you stop the anticoagulant therapy. That is the reason why the guidelines were formed, to make sure that the patients do not suffer again a thrombotic event by stopping the drug. But at the same time, by continuing the drug, there is a possibility there can be intraoperative bleeding, or the anesthesia procedure itself can land up with a bleeding complication like a hematoma in the epidural space, or a intraventricular, intrasubarachnoid area. So you must have a balance between prevention of thrombotic event in the patient as well as preventing a bleeding episode during the anesthesia procedure, and that is the reason why all these guidelines were given. So if you know that point, then you will be able to choose that. And before you stop, give advice to stop the drug. You must make sure that there is no risk of thrombotic complications that can happen in the patient. In case you are using, most of the oral drugs have got a need to stop them for at least 3 to 4 days prior to the onset, we plan the procedure, because they have a long life action in the body. So you have to stop them well in advance, so that especially antiplatelet agents, once they get attached to the platelets, then they don't allow them to function in a normal way. That is why until the new platelet is formed, which is what is the lifespan of a platelet?
5 days.
5 to 7 days.
5 to 7 days.
So until the new platelets are formed, the coagulation will not happen in the normal way. So most of these drugs have to be stopped well in advance, and then in case there is a risk of thrombus formation by stopping this drug, then you can switch over to a short-acting drug, which can be having a half-life of only 4 to 6 hours, like heparin, or a low molecular weight heparin, which will have a half-life of about 10 to 12 hours, so that you can prevent the incidence of thrombus formation. At the same time, you can avoid a bleeding episode during the surgical or anesthetic procedure also. So that is the basis that you have to remember. So we'll just quickly go through the presentation.